When a patient of corneal ulcer come to our OPD, we have to identify whether it is bacterial or fungal ulcer. Predisposing factors are local factors. Causative organisms include bacterial, fungal and viral. And pathogenesis include corneal abrasion followed by recruitment of inflammatory cells to the site and presenting symptoms. Bacterial, fungal and viral ulcer vary. Fungal has more signs than symptoms and investigations include bacterial has corneal defects with large staining infiltrate, whereas fungal gray or whitish stromal infiltrate with indistinct fluffy margins and satellite lesions. Viral keratitis has dendritic pattern and reduced corneal sensations. Protozoal ulcer will give history of swimming in a pond and causative organism is acanthamoeba causing perineural infiltrates, discontinuation of contact lens wearer and treatment of bacterial, fungal and viral corneal ulcer as above. For protozoal, give topical amoebicides and treatment failure we must treat.
So you can see this cornea here. The patient is complaining of mild pain, mild irritation, and you can see the conjunctiva is not that very inflamed here, but you can see something here, right? You can see two areas of some vague infiltration, which now shows up slightly better when you stain with fluorescein, right? So when in doubt, when the patient is complaining of irritation, when you don't see much, so I'll just show you the slide before. There is a possibility that we would have missed this, but if you have stained this, you really get this picture very clear for a pseudodendrite, and you stain it with a fluorescein and see it with cobalt blue filter, you see the same lesion much more clearer. You can even appreciate that this lesion is not connected to this lesion, and this lesion is not connected to this lesion. So this is what we mean by satellite lesions, and I'll also explain to you more better. So as you can see, this is more like a flower pot dendrite. You see something like a base here, and it's accompanied by stromal infiltration. It's not a clean linear dendrite as you would see in viral keratitis. This is more like a flower pot dendrite. I like to call that way. So it's something like a pseudodendrite. But then staining with fluorescein and seeing with cobalt blue helps you catch these things. So we did a study. This was done around 10 years back. We showed pictures from a trial which I did, the mycotic ulcer treatment trial, the MUD study, and we shared it across the cornea specialists in India and in the US. And you guess what? We are not talking of ophthalmologists, we are not talking of residents, we are not talking of fellows. We are talking of established corneal surgeons. And when they saw the photographs, only 60% of them got it right by just looking at the photograph and guessing whether it was fungal or bacterial keratitis. So none of the clinical features which I had mentioned before was very significant, but one thing which had a lot of specificity to fungus was the feathery edges. And so you were right when you answered, if it is one thing which you need to uh, uh, say whether it's caused by fungus, it is feathery edges. So the next part is the raised surface. See, here you can see, as you can see, this is something like a plaque. You see this part? This is almost like something sitting on the cornea. So this is what we mean by a raised surface. So again, you see, in the initial part of the infection, the lesions are pretty dry because, as I said, the lesions become wet when the inflammatory things progress. And the inflammatory things progress very slowly in a fungal corneal ulcer. And that's the reason why you have a dry surface in a fungal corneal ulcer, and also sort of an elevated surface with a fungal corneal ulcer. So this slide shows the satellite lesions much better. If lesions like this exist, you don't have any doubts. But you have to also understand that these slides are handpicked for me to deliver this lecture and to make it clearer for you. The fungi sometimes don't read textbooks, and so they don't present it in a way where we want them to be. And so without the aid of microbiology in real life, it's really difficult to confirm a diagnosis of fungal keratitis. As you can see here, to be truly to call this as an endothelial plaque, we can call it, but we cannot be as specific as we were with the feathery margins. Immune rings are also a hallmark of any infective keratitis for that matter, and it can be seen, and I'll show you some slides later. When pigmentation happens, the diagnosis is fairly clear. As you can see, very nice pigmentation. This is almost like a leopard skin, right? This was aspergillus again, and aspergillus teres. You have multiple things, but when something like this is there, you have to be careful, especially when you are not able to see the pupil fully. This can either be a pigmented lesion, or sometimes you can mistake a sort of a perforated ulcer
Yes,
for a big
perhaps.
lesion here. And so the best thing to confirm it is to see whether the pupil is round or not. Herpetic dendrite. A herpetic dendrite commonly is often a long dendrite. It's not a short one. See, it's a long linear dendrite, and often it actually crosses the visual axis or someplace, but it's always slender. It's not broad. It's not broad. But see this fungal keratitis thing, there is a stromal infiltration always. And if you look carefully, even here, this is as it is not very linear like this. See here, this is something which is almost like a mermaid dancing. That is like a viral keratitis. While here, this is much more shorter and also stockier. So that is the main difference. So in real life situation, if you are in doubt, and if the patient is having comparatively a quicker onset, and is very clear that the patient is he gives a history of foreign body fall, I would rather treat it as fungal ulcer for a couple of days before being certain whether it is uh, fungal or viral. So in doubt, treat a dendrite as a fungal keratitis unless it is very, very clear like this. So with bacterial keratitis, you really cannot differentiate. So here you see this is fungal, this is bacterial. We were always taught that the edges of the fungus, you will have serrated margins. Here you see a perfect circle. So you really cannot differentiate between fungal and bacterial after a process of time. You can all these definitions like the pseudodendrite part or the feathery margin part are very typical when you start off in the early part of the presentations, but over a period of time, it just gets merged, and it's very difficult to differentiate between a fungus and a bacterial keratitis. Acanthamoeba keratitis is often taught as a circular disc-shaped stromal infiltration. So here I'm showing you 4 different circular ulcers, each competing for the price of the best circle. This is a circular ulcer caused by fungus. This is a circular ulcer caused by gram-positive cocci. This is a circular ulcer caused by nocardia. And this is a circular ulcer caused by acanthamoeba. So if you can see here, this is a nocardial circular ulcer is typically described as a wreath-shaped ulcer here. But see this one. If you just see this, you might just diagnose this as acanthamoeba, right? This is a perfect circle. In fact, this is a better circle than even this. But so this is why we need microbiology to confirm our diagnosis. But before we go into microbiology, we can use confocal microscopy. And with confocal microscopy, a confocal microscopy cannot identify bacteria because the bacteria size is too low. So fungus can be identified and acanthamoeba can be identified. So this is how the fungus looks as very, very clear very clear structures.
If you are dealing with a patient who is suffering with a rapidly progressive disease and a suppurative infiltrate on cornea, more likely that the etiology is bacteria, particularly the more virulent bacteria, and these include Staph aureus, Strep pneumoniae, Pseudomonas aeruginosa, and Neisseria gonorrhea. Even to the extent that if you are dealing with a case of parasitic or fungal keratitis and they suddenly show a rapid deterioration in clinical picture, it is an indirect evidence that there is probably a secondary infection by bacteria. And all of those patients must be investigated and corneal scraping should be done in order to arrive at a definitive diagnosis. On the other hand, if you are dealing with a slowly progressive disease and a localized infiltrate, as shown on this slide, uh, you are more likely to be having infection by fungi or protozoa. Only rarely, some of the low virulent bacteria can lead to this kind of clinical picture. And these bacteria mostly belong to the actinomycetal group, which is nocardia and atypical mycobacteria, or moraxella. Among staph epidermidis, which is usually a commensal but can occasionally cause infection, and therefore the clinical picture becomes a slowly progressive disease. So if somebody asks you that there is a bacterial infection and you find that the course is a slowly progressive disease, you can think about nocardia, atypical mycobacteria, moraxella, or staph epidermidis. They are the more common causes of a slowly progressive bacterial keratitis. Otherwise, close to about 80% of the time, this kind of a clinical picture is suggestive of fungal or parasitic infection. Now, there are definitive diagnosis, there are definitive features that also help you arrive at a diagnosis, which we called as organism-specific characteristics. The gram-positive cocci, for example, produce a suppurative infiltrate, but a well-defined edges. If you see this, you see a very well-defined edge. Surrounding cornea shows mild to moderate reaction. And anterior chamber reaction also varies depending upon the virulence of pathogen. Compare this clinical picture with a gram-negative bacteria infection. Here, the borders or the edges are ill-defined, and the surrounding reaction is so intense that you are not able to make out where this infiltrate is ending. Is this the infiltrate edge, or is this the infiltrate edge? And that is because these organisms induce very severe host response, and therefore there is a lot of infiltration by leukocytes. And at the same time, they also lead to liberation of lot of exoenzymes, and therefore the degree of tissue destruction in gram-negative bacterial keratitis is much, much higher. How about moraxella? As I told you, moraxella produces a slowly progressive disease, usually in corneas that are predisposed. For example, a patient receiving corticosteroid therapy, a patient having edematous cornea with bullous keratopathy, a patient having recurrent corneal erosion due to corneal dystrophies. And these are particularly macular corneal dystrophy, lattice dystrophy. So they develop frequent breakdown and they keep using drugs indiscriminately and they become vulnerable to get infection by moraxella. So if you have a predisposed cornea, a slowly progressive disease, and a localized infiltrate with a well-defined edges, mild reaction in the surrounding cornea, and mild anterior chamber reaction, you must suspect moraxella as an etiological agent. Neisseria gonorrhea, on the other hand, is an extremely rapidly progressive infection, and many times these patients present as conjunctivitis. And if you are not able to diagnose and appropriately treat these patients, you will find that the next day the entire iris or the uveal tissue will be seen in front with the entire cornea being destroyed. So it's such a rapidly progressive disease that within 24 hours the entire cornea may melt. Now, what is the characteristic clinical picture in this patient? Is a exposure to sexual interaction. So you must establish that history, and that will lead you to the diagnosis. The treatment is more systemic rather than topical, and therefore this diagnosis or making this diagnosis becomes very, very crucial. Nocardia typically produces a wreath-like infiltrate on the cornea. Now in this, you will see multiple raised calcareous lesions that are arranged in a wreath pattern. At times, you may see filamentous extension into surrounding cornea. And this is very, very classical finding. If you do corneal scraping and pass a 15-number surgical blade or Kimura's spatula, you will get a gritty feeling, almost like as if you are passing blade on a sandpaper. So this is very, very common finding. We will talk about nocardia in detail, where we will talk some of the uncommon findings also. But you must be familiar with this classical finding of wreath-shaped infiltrate. Atypical mycobacteria, again, we will talk in detail in the last portion of our talk, but these patients have a waxing and waning infiltrate. You start treatment, the infiltrate will show some improvement, but then they again show worsening. You change the antibiotic or put them onto a different set of antibiotic, they again start showing some resolution, and then they worsen again. And many times these patients are treated with corticosteroids because people feel that it is an inflammatory response. On the what it results into is that more widespread dissemination of these organisms into corneal stroma.
The tray includes 15 number blade, 2 slides, blood agar and Savoyard's dextrose agar. This is the list of the various stains and media used for corneal scraping. 15 number blade is used for scraping. Sharp end of the blade is used to scrape the edge of the ulcer. Material is smeared on the slide for gram stain. At the same time, slide is labeled with name and MRD number of the patient. For KOH, material is inoculated by tapping it on the slide. Slide is labeled with MRD number and name of the patient. After this, more material is obtained for inoculation on culture media. Material is inoculated on blood agar in the form of C shapes. Also, it is inoculated in SDA, taking care that the tip of the needle should not touch the test tube and goes directly into the media. Next step is incubation of blood agar and SDA. Blood agar is incubated in the incubator and the temperature is set at 37 degrees Celsius. SDA is kept at room temperature. Next step is KOH mount preparation and gram staining. KOH preparation is done by instilling few drops of 10% KOH solution and covering it with a cover slip. The slide is viewed under the microscope. First, 10x lens is used for focusing the field, and then the magnification is increased to 40x. The slide is adjusted on the microscope as shown. So these are the fungal hyphae seen on KOH mount and growth of same hyphae on SDA. Gram staining is done as per the standard protocol. This is the immersion oil used for 100x immersion technique. Few drops of oil are instilled on the gram stain slide and it is viewed using 100x oil immersion technique. The slide is focused on the microscope as being shown. So these are gram-positive cocci seen on gram stain and growth of same cocci on blood agar. We can also see stained fungal hyphae. These are the gram-negative bacilli, growth of same bacilli on blood agar. These are the acanthamoeba cysts seen on KOH mount and gram stain.
The best definition of fortified antibiotics is exemplified by the following. The use of reformulations of parenteral antibiotics as eye drops with non-marketed composition or concentrations. So either the required drug is not available commercially as eye drops or not available in a concentration that would provide optimal results in severe infections. Combination therapy with fortified antibiotics is generally not the first line of treatment for mild to moderate bacterial keratitis, as monotherapy with commercially available topical fluoroquinolones has been shown to be just as effective. However, they may be considered in the following situations. Large and or visually significant corneal infiltrates, especially if a hypopyon is present. In severe infections, to obtain a higher available concentration of the drug. Eyes unresponsive to initial treatment. When drugs for specific organisms are required and which are available only in parenteral form, for example, vancomycin. Where fluoroquinolone resistant cases, example MRSA and resistant pseudomonas, post-trabeculectomy blebitis and endophthalmitis. Now you've chosen to give fortified antibiotics. Which ones do you choose? When the organism is not known, none isolated, or when multiple organisms are present, a combination of two drugs, one to cover gram-positive organisms and one to cover gram-negative organisms is used. The usual combination is 5% cefazolin for gram-positive organisms and 1.4% tobramycin for gram-negative organisms. Alternately, a 5% vancomycin may be used for gram-positive organisms. However, unless specifically indicated, cefazolin is preferred as it is less toxic to the ocular surface. Alternately, for gram-negative organisms, 1.4% gentamicin, 2 to 4% amikacin or 5% ceftazidime may be used. If the type of organism is known, then specific antibiotics may be used. Cefazolin or vancomycin for gram-positive cocci, tobramycin or ceftazidime for gram-negative rods, ceftriaxone or ceftazidime for gram-negative cocci, and clarithromycin or amikacin for atypical mycobacteria. There are other antibiotics that are used less commonly. Since we said that these are not available commercially, let's see how to prepare some of the commonly used fortified antibiotics. The methodology is the same for both cefazolin and ceftazidime, as both are available as vials containing 1 gram of powder. Since we require a 5% solution, this means the concentration is 50 mg per ml. So add 9.2 ml of artificial tears to the vial to get a total volume of 10 ml that contains 1000 mg of antibiotic. Now take 5 ml of this solution, which should contain 500 milligrams, and dilute further with another 5 ml of artificial tears. So we have the same 500 milligrams now in 10 ml of solution. This is a concentration of 50 milligrams in 1 ml, which is what we want. Vancomycin is also required in a 5% concentration. To one 500 mg containing vial, add 10 ml of either 0.9% sodium chloride without preservatives meant for injection or artificial tears. This gives you a 10 ml solution containing 500 mg, that is, there is 50 mg per ml, that is 5%. For tobramycin or gentamicin, withdraw 2 ml from an intravenous vial that contains 40 mg per ml, that is 80 mg of the drug, and add it to a commercially available topical solution to give 14 mg per ml or 1.4%. Are there any drawbacks to the use of fortified antibiotics? There is an increased risk of ocular surface toxicity, especially with prolonged usage. 1, because of the increased concentration of the drugs, and 2, because of the free radicals that form if no preservative has been used. Hence, these drugs should not be used beyond 7 days. These drugs may retard epithelial healing. Increased tonicity of fortified drops induces reflex tearing, which can dilute the medication and reduce tissue penetration. These drugs can be stored at room temperature for just a week, after which they must be discarded. They may be used for up to a month if stored at 4 degrees centigrade. Some centers freeze the preparations at minus 20 degrees centigrade, permitting them to be used for up to 6 months. This way, the pharmacy needs to prepare these antibiotics just twice a year. The risk of contamination is always present when compounding mixtures, and hence the need for careful preparation in a sterile environment. Of course, fortified antibiotics are more expensive compared to commercially available antibiotics.
Second day is make a diagnosis, and if not possible, make a list of differential diagnosis. Sometimes it's not very much clear on the first go. Then choose a drug, then choose a dose. In dose, it's very important that you realize that in ulcers, we need initially a dose during sterilization phase, and then we need to reduce the dose during the healing phase. So starting with the first story. This 41-year male, he had some wooden body fall in his eye. He removed on his own. And next day, he realized that there is some problem. Visited ophthalmologist. Ophthalmologist started moxifloxacin in 2 hourly dose. After 2 days, when he again visited that doctor realized that patient has worsened with moxi 2 hourly, and that patient was referred to me. So in this case, as you can see, most of the infiltrate is central. It's patchy. There are few satellite lesions, and there were endoexudates. Sorry, I don't have the slit lamp picture, but there were some lesions which were on the endothelium only. So most of our ulcers are bacterial or fungal, though there can be sometimes rare organisms. So major thing is initially to know that in what category it falls. So in institutes, they do the detailed workup. When you will go out in your practice, you might not have access to all these. Even if you just do the scraping for the smears, that will be enough in many of the cases. Most important thing is KOH. I have made a 10 minutes video. If you are interested, you can go to YouTube channel and see it. And initially always do a stain, know where is the defect. And that is the point from where if you do the scraping, the chances of getting a yield will be maximum. So we did scraping. Both KOH and grams were negative. So as we usually do, if both are negative, we treat it as a bacterial. So we thought that, okay, we will treat it as a bacterial ulcer. Now comes which drug you use. As you know, if the ulcer is small And superficial, we go with the monotherapy. We choose a 4th generation fluoroquinolone. And if the ulcer is severe, then we go with the combination therapy, where we choose one drug for gram positive and we choose one drug for gram negative. Okay, and you must remember that whenever you have made a fortified drug, it should be re-prepared after 7 days, and it should always be kept in. Can I have some interaction? Where should be the fortified drugs go? Not in phone. Where should a fortified drug should be there? Have you ever made a fortified drug? Then what do you tell your patient? Put it in fridge. Okay. So initially the dose should be 1 hourly. That period can be 2 to 5 days depending upon the response you see, because at that time we want to kill most of the bacteria. No NSAIDs. And even lubricants don't have any role until unless patient is having concomitant problems like dry eye. Otherwise the ulcer patient is already watering a lot. And then you have to taper the drugs. So I started these drugs and then I examined patient after 2 days. Now is your turn. This is the game. This is after 2 days. You have 10 seconds. Is there any difference between these two? Chalo, 10 seconds are over, no response. So this was the area of endoexudates. So endoexudates have decreased. But the most important thing is somewhere else. If you notice this area from 3 o'clock to 6 o'clock, this area was very hazy here. And now this area is clear. This is one of the most important indications that our drugs are working. So pre and post, this area was the area of cellular reaction. Near the infiltrate, you will always find lot of WBCs, which give the haze to the cornea. If the cornea is responding, that haze will decrease. So always look for that area. Other positive things are if the patient is subjectively feeling better, hypopyon is less, the density is less. And if your patient is not improving at all, always check compliance. And third thing, if your patient has worsened, always repeat KOH. You might have missed it in the first go. And then you start decreasing the drug. It is very essential to decrease the drug. So I decrease the drugs. This is how the patient looked at 1 week. At 2 weeks, when most of it has healed, then we don't need to continue fortified. We can change to monotherapy also. And this is how the patient looked at 2 months. So the importance of cellular infiltration is that, suppose this is the patient who got injury post-accident, he got redness in the eye. Infiltrate was very small. Sometimes if the infiltrate is very small, it is too much in the periphery, sometimes we don't scrape. So in this patient, I did not scrape. I started the patient on antibiotic only. When patient came after 2 days, do you feel the infiltrate has increased or decreased? Deaf and dumb. At least you can tell it has increased, decreased. Infiltrate appears, increase. It has increased a bit. But then I told you there is another factor. Always pay attention to surroundings. His surrounding area was clearer. So sometimes it happens that during the consolidation phase, the infiltrate slightly increases the size. But if the surrounding area is better, you can observe the patient. There is no need to further increase or add the drugs, making it a cocktail. Otherwise, it will worsen, as it happened in our last case. This patient was using contact lenses for last 25 years. He occasionally used to sleep with those. So he got some ulcer. He was referred to me with this. Ulcer is looking very dense. 6 days back, he consulted our doctor. At that time, he was put on this cocktail. Neta, Amica, Moxie, no scrapings were done. Even oral antibiotics were given. And after 2 days, furthermore, Vanco, Cefta were also added. And when he did not respond, he was referred to me. So this is the picture at his present. So as you can see, the surrounding area looks pretty much clearer. Hardly any cellular infiltrate, no edema. And when I did the scraping, I realized that entire dense looking thing was just a necrotic mass. It just came out like a pus. And on scraping, there was no organism. So I stopped all the drugs, put only on Moxie 6 times a day. And this is how the patient responded. So ulcer is not only about increasing the drugs always. So always document, note the surroundings also, always do KOH, and if patient is not responding in your hands, always refer. Thank you so much.
Thank you, Dr. Sujata, for excellent presentation and excellent stories. I would just